Hello, and welcome back to Wellness Wednesday, where we share practical wellness tools and techniques from experts on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger from Rolfe Pancreatic Cancer Foundation, and I'll be co-moderating tonight's Wellness Wednesday installment with Savina Chacheva and our partners over at Cancer Wellness Center. It's sure to be a truly meaningful conversation. For our friends joining us through the Cancer Wellness Center, let me share a little bit about Rolfe Pancreatic Cancer Foundation. We're a local Chicago organization with connections to some of the leading pancreatic cancer hospitals and organizations in the Midwest and beyond. Rolfe Foundation provides personal and tailored support to patients, survivors, and families in crisis by connecting individuals with medical experts, personalized resources and education, creating awareness about risks and symptoms, and funding early detection research. Our hands-on approach ensures that no one has to face this alone. So what does this look like? So we do this by directly connecting patients and their families with the medical experts and specialized resources. We also fund research because we understand that the best chance of saving lives is through early detection. And we provide ongoing education and support, like our panel tonight, to empower patients and families to make quick decisions with confidence. So you could learn more at rolfefoundation.org or look at the link in the chat and connect with us through our social channels as well. Now I'd like to welcome my partner tonight, Savina Chacheva from the Cancer Wellness Center. Hi, Savina. I almost said good morning.
Thank you, Erin. Good evening. As always, it's a pleasure working with you and Rolfe Pancreatic Cancer Foundation. Good evening, everyone. Thank you for joining us tonight. For those of you new to the Cancer Wellness Center, I would like to take a minute to tell you more about the center. The center is a nonprofit organization aimed to improve the emotional and physical well-being of everyone impacted by cancer and their families. Our services include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis, wellness classes like yoga, tai chi, meditation, stress reduction, and more that provide a holistic approach to healthy living, and support services, including counseling and support groups that are designed to help patients and their loved ones, as well as those bereaved, manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat. Thank you.
Thanks, Savina. Before we get started, Savina and I both wanted to acknowledge that tonight's topic could be an emotionally charged one. After all, we're going to be talking about everything from grief to difficult decisions and conversations surrounding advanced care planning and important questions to consider for end-of-life planning. They're all topics that are too often taboo and uncomfortable or simply ignored, and they can bring up feelings of vulnerability or shame or fear. And we also understand that each of you joining us tonight is doing so from a different stage and with a variety of experiences. We know that no two paths are alike, but we can walk those paths together. So I ask that tonight you give yourself the permission to participate in whatever way feels best for you. So if you're comfortable asking questions directly in the chat, please do so below. If you want to ask questions in a more private manner, you can do a private message in the chat, or you could email us at info@rolfefoundation.org, and we'll get them answered as well. Finally, tonight's session will be recorded. So if you are unable to stay for the whole time, please know we'll send it out and it'll be on Rolfe's website. And I'm pretty sure Cancer Wellness is as well, or their YouTube at rolfefoundation.org, and they'll put the links in the chat as well. Tonight, we have three amazing speakers. We have Dr. Mary Mulcahy, who's a professor at Northwestern's Feinberg School of Medicine, Celeste Galletti from Life Matters Media Board of Directors, and Priscilla Andrews, the Clinical Manager of Cancer Wellness Center. I'll let each share more about their background and experience, but first I will introduce Dr. Mary Mulcahy. I am having trouble with names tonight. Dr. Mary Mulcahy and Celeste Galletti. Welcome, ladies.
Thank you. Hi, everybody. Thank you for inviting me. So I'm Mary Mulcahy. I'm a medical oncologist at Northwestern University, and I specialize in treating GI cancers. So pancreas cancer is one of the diseases that I treat and have been doing for 20 years now. And we have seen advances over these 20 years, which is exciting, certainly not as many as we need to, but there's progress being made. And it's organizations like the Rolfe Foundation that make that happen. And it's organizations like Cancer Wellness that allow us to provide support to everybody as they're going through these treatments. So in addition, I have been interested in helping people to prepare for end-of-life planning. And this is so important for everybody. And that's what I think that's what I really want to get across, is that end-of-life planning is something that everybody needs to do. I think people who are diagnosed with cancer and people who are diagnosed with a potentially incurable cancer, it just becomes a little more urgent. But you have the luxury of understanding that, yes, this is happening, and I have the time to plan for these things as best as possible. We can never plan for everything, but we can plan for some of these things. So one of the ways we've done this is through this organization that Celeste and I were founders of. Whoops, why isn't it advancing? There we go. Called Life Matters Media. So we started an organization called Life Matters Media, and the goal of this is to provide information, resources, and support for all involved in end-of-life decision making. And that's how I became involved with Wellness House. So through this organization, we did educational sessions and a lot of boots on the ground, one-on-one, helping people. So because of this recent crisis that we've all been in, we have not been able to provide the resources that we wanted to the community. But I'm so happy to be back with people from Wellness, where we've done a number of these sessions in the past. So I don't want to take up too much time talking about us. These are some of the programs that we have done in the past. What we're going to talk about today is starting the conversation, identifying values and goals at the end of life. So this is something that's important for anybody, people who have elderly parents. We've seen people with advanced cancer. Now, this recent COVID pandemic we've been in, this has sort of been brought to the surface. But the difference is that people don't have time to have these conversations. Things happen so quickly and people got so sick so fast that there wasn't the time to have these conversations about what would you want to do if you couldn't get your breath in all of these other conversations. But now in the calm is when we should be doing this, not in the crisis, so that we can think more clearly, we can talk these things out, we can make sure that everybody is being supportive of each other, and we can identify what those goals and values are that we want honored at the end of life. And then we're going to get into some of the details about your care preferences. Where do advanced directives fit in? What is an advanced directive? How does this help you? What do you do to get an advanced directive completed? We also have done other sessions on caring options, talking about palliative care, hospice, and our fourth session has been on final matters. I get a lot of calls. I got a question today of a patient that I saw in the office who says that when the time comes, how do I donate my body to science? And we had a whole discussion about that. And this is not something that most oncologists are talking about. I do because of my involvement with the organization, but aside from that, it's something that isn't really out there. So it's hard to get the information. Okay, so my last slide, I'm going to turn it over to Celeste in a minute, but I kind of want to set the scene for what she's going to talk about. So we talk about a quality of care plan. Anybody who's been through a cancer therapy or through any sort of medical therapy, oftentimes there's a plan. Here, we're going to do this. We're going to do this treatment. We're going to do this chemotherapy. Then we're going to do radiation. Then we're going to operate. Here's what we expect to have happen. There's a care plan. So what we want to encourage people to do is make a quality of care plan. How do you have the best quality care when the cancer therapy is no longer working? So there's basically three main things to think about. One is the first thing that has to occur is that people have to accept the reality of their own mortality. So that's a big one. And oftentimes when somebody gets diagnosed with cancer, that's when they first think, okay, I'm going to die someday. Other than that, it's easy to kind of put it off. But even if it's a curable cancer, having cancer is scary, and having cancer changes people. It's always in your brain that you had cancer, even when it's a curable cancer. So accepting the reality of our own mortality. Discuss the goals of care. And this is so important. When you're undergoing therapy, understand what the goal is. Are we doing this to cure it? Are we doing this to help me live longer? Are we doing this so that I feel better? So you have to understand why you're doing the therapy that you're doing, and so that you can work with your healthcare team and make sure you're meeting those goals. So if the goal of care is to have the best quality of life for as long as possible, then it's up to you to be an active participant in your care to make sure you're understanding, what is my quality? Is this the quality of life that I want? And then the third thing about a quality of care plan is that it needs to be consistent with what your own beliefs and values are. So there's no textbook where you can look up how to make a quality of care plan. It's really based on, what do I believe? What's important to me? And you need to be able to kind of put that into words so you can relay that to your healthcare team so that they can help you to meet those plans, and so meet those beliefs and those values, know where you're coming from. So this is a lot. I understand that all at once. And I'm going to turn it over to Celeste, who's going to share her personal story with you. And then we'll come back and we'll talk about some of the details.
Thanks, Mary.
Stop sharing.
Okay.
You don't need to see me anymore.
All right, and I'm going to share, make sure I am started there. Okay, is seeing the slides? Somebody confirm? Okay.
Perfect.
All right, that's the hardest part. Okay, well, thank you again. It's such an honor to be here with you today. As Mary mentioned, I had joined Life Matters Media when we started, and it was largely based on the personal experience that I'm going to share with you. My story began in September 2002, less than 2 years after my husband Lou and I were married. I always say I saw the hospital number flashing across the caller ID, and my heart raced as I heard my 31-year-old husband's unsure voice telling me that he had a seizure while driving and was awaiting a CAT scan. My stomach dropped, my legs kind of gave out from under me, and I just began to shake, tremble on the floor of our condo that we had just moved into 2 weeks before. Did not know then the cause of the seizure or the eventual outcome, but I knew something had drastically changed. I told Lou how much I loved him, that I'd meet him shortly, and hung up. I was paralyzed, sitting on the floor, and wanted to see him with every fiber of my being, but I just wasn't ready to face the world outside kind of the safety of the home we had just built. So I gave myself a few minutes. I told myself to pull it together and headed out the door. When I arrived at the hospital and saw Lou sitting alone in his pastel hospital gown, tears welled in my eyes. I'd never seen my strong, young, healthy husband look so vulnerable. Sat on the bed holding his hand. His family began to arrive, immediately bringing a sense of comfort. However, the comfort was short-lived as the on-call neurologist and his gaggle of wide-eyed residents walked into the room. All about our age, none of them would look directly at me. I even caught a couple of tears in their eyes. And I thought to myself, this can't be good. The neurologist then began to speak. Something about a mass in his brain, getting our affairs in order, alerting out-of-town relatives. I honestly don't remember most of what he said next, but will always remember the faces of the young residents, naive like me, to all they would experience and witness in the coming years. Luckily, what seemed like the end was only the beginning of our journey. Over the next 5 years, we would have 3 brain surgeries, radiation, and countless courses of chemotherapy. But in between these treatments, we traveled every chance we could, including renewing our vows on the Amalfi Coast of Italy and island hopping in Hawaii. leaving our anxious family to worry about us at home. What if Lou had a seizure? What if he ended up in a hospital in a foreign land? The what ifs were endless, but time was potentially not. It was only after we were able to grieve the loss of the life that we were not going to have that I believe we were truly able to embrace the one that we had been given. I remember one night, kind of tears streaming down our cheeks as we grieved the child that we would likely not have in the long life that was no longer certain. The reality is, life is never certain. However, for me, it was not until we were faced with death that I truly understood this. So now, instead of celebrating buying a house or having a baby, we celebrated every stable MRI in the hope of more time together. After a routine MRI revealed significant growth of his brain tumor, we needed to discuss how we would move forward. And after discussing the risks of various treatment options with our medical team, we decided that Lou would start a new treatment protocol. At the time, we didn't really understand fully what alternatives to treatment might be. In retrospect, we could have addressed this with our medical team, and I'm not exactly sure why we didn't, but fear of disappointing was definitely part of it. After all, they wanted so much for Lou to do well, and what if that wasn't the case? We didn't want them to ever feel like they were letting us down. Also, Lou took great pride in being a survivor and facing each new treatment head on. What would happen if he shifted his care goal? Would people think he gave up? Would he be abandoned by his healthcare team? Would he still be a survivor? So many questions swirled through our minds. The good news is that Lou's brain tumor began to shrink in response to this new treatment. The bad news is that his blood counts dropped so drastically that he ended up in the ICU with a lung infection and developed blood clots in both of his legs. So now, instead of enjoying our time in the home we love so much, we would need to set up a new home in a nursing home where we would live for several months as the blood clots resolved and Lou gained the strength to walk again. This was the first time we questioned if treatment was always the right decision and contemplated the notion of quality of life versus quantity. Despite the endless supply of Chips Ahoy and Lorna Doone cookies, living in a nursing home was definitely no place for a 35-year-old. One night after dinner, Lou sat me down and said that although he felt good and remained full of hope, he accepted that he had a serious illness and he wanted to discuss his end-of-life wishes and decisions that he would want me to make on his behalf if he was no longer able. I was shocked and resistant at first, but quickly realized how important this conversation was for Lou and ultimately for me. I never felt for 1 minute that having these conversations took away hope from Lou. To the contrary, the conversations seemed to empower him and free him to live more fully. The elephant in the room had finally been addressed, and it was as if a weight had been lifted off his shoulders. One of the things that Lou shared with me was that he absolutely did not want to die in a hospital if at all possible. To Lou, the hospital represented illness, sadness, and stress, not the peace and comfort that he valued and sought at the end of his life. Had we not had this conversation, Lou would have likely been one of the many individuals that, despite not wanting to die in a hospital, ultimately does so. Back in an adjusted dose of his treatment protocol, we celebrated a couple more stable MRIs before his tumor began growing once again, and Lou's seizures were becoming more frequent. After one such seizure in the middle of the night, we were once again on the all too familiar path back to the hospital. But somehow this time it felt different. After consulting with our medical team and determining that there was nothing more that could be done in terms of medical treatment, we decided to initiate a discussion about hospice care, which everyone agreed was aligned with Lou's wishes. However, Lou's family was adamant about keeping him in the hospital. I think they believed that as long as Lou was in the hospital, there was the possibility that something more could be done, and they were not ready to confront the reality of the situation themselves, which is very understandable. However, because of our conversation, I had the confidence to push even harder for Lou to be transferred to a nearby hospice facility. One of the moments I will always remember is Lou looking up and acknowledging that he was no longer in the hospital, breathing a sigh of relief and thanking me. The room was full of comfortable couches and chairs and had sunlight pouring in from the oversized windows. Such a stark contrast to the hospital environment and its fluorescent lights and beeping monitors. My thoughts were interrupted when the attending physician came into the room. He assured me that the team would keep Lou as comfortable as possible. However, there was an important decision that needed to be made. As a result of Lou's seizures, there was concern that providing fluids could be harmful. The doctor patiently and supportively provided guidance based on his vast experience, while ultimately letting me make the decision to withhold fluids and allow the process to unfold naturally. A decision that I knew was aligned with Lou's current goals of care based on our conversation regarding his end-of-life wishes. Over the next few days, Lou was surrounded by family, friends, and coworkers. Yes, there were tears, but there was laughter as well, and we shared memories, both bittersweet and funny. We were grieving, but more importantly, hospice provided us with an environment that was conducive to celebrating Lou's far too short but beautiful life. As the process progressed, we needed to discuss another decision, which is whether Lou should be sedated given his ongoing seizures. Again, the hospice physician knew the weight of each of these decisions as he acknowledged my feelings and answered my questions multiple times over. We ultimately agreed that this was the right thing to do to ensure Lou's comfort and what he would want. On the fifth evening, as the end was growing closer, each of Lou's closest family and friends spent time with him alone. Around 1:30 that morning, after everyone had left, I held Lou's hand as he peacefully took his final breath. Some would tell you that the years after Lou's diagnosis were marked by constant treatment, including brain surgeries, chemo, and radiation. I would tell you that they were marked by 6 wedding anniversaries, 5 years of survivorship, and a lifetime of memories created. I am forever grateful to Lou for initiating this vital conversation. Because of these conversations, I was blessed to have the clarity to know that I had made decisions that he would have wanted me to make on his behalf, which brought me a sense of peace after he was gone. It truly is a gift we can give our loved ones. I am now going to turn it back over to Dr. Mulcahy to discuss the advanced care planning process and how to start this vital conversation. But first, I want to thank you again for allowing me to share my story with you.
All right, I'm going to need a minute here. Thank you, Celeste. All right. My video's on, right? Okay. Well, thank you so much, Celeste. I can't thank you enough for sharing that with us. It's obviously not an easy story to tell, but I hope and I suspect you enjoy thinking about Lou and talking about Lou and being able to share that with everybody. So thank you. It's very meaningful. I want to talk about a few things. I want to go on with this conversation. So Celeste talked a lot about how important it was that they had this conversation and all of the things that it relieved Lou of some of the things on his mind. And he helped to prepare Celeste, which is the ultimate gift that you could give your loved one. So how do we go about doing this? There's a lot of ways to approach this. But usually when we have these discussions in the past, we've been in a live group. So this is very different being on video. But a lot of times this is where we kind of think about, we get very interactive and people share the answers to some of these questions that I'm going to bring up. So I want you to think about this and pretend we're in a big group. And if you were being asked to share, think about what you would share. So one of the most important questions, like to start thinking about, not one of the most important, but one of the questions is whether or not you've thought about the medical care you would want at the end of life. So a lot of people would say that they want to be in their own home, or, we get a little deeper. Do you want music playing? And, they can describe a scene that they would want, or they say, I want to be pain-free, which certainly would be important. So there's a lot of different things that we've heard from people about the medical care they would want at the end of life. And then there's people, and I see this every day, that want to be getting every treatment possible in order to add more days to their life. And that's a great answer too. These are very personal questions. There is no right or wrong. If there was a right or wrong, we wouldn't be having these conversations. And there isn't. It's very personal. This is your time for you and your family, and you only get one shot at this. And so putting some thought into what you would want at the end of your life, what's important to you, how would you want to spend that time? The next thing is to discuss it with somebody. Have you discussed that care with someone else? Does somebody know? Because for you to know and to have your ideas is fine, but it's really important that you share that with other people so you have an opportunity to discuss it. So if somebody says, when I'm no longer going to benefit from this treatment, this is what I want. You need to share that with someone so they can understand why you want that and make sure it happens for you. So discussing that care with somebody. And then for you to think about what challenges in considering or discussing these issues do people experience. And Celeste discussed some of these. So we can all think about for ourselves what we want. Maybe you can discuss it with somebody, but it's not easy. Why isn't it easy? It's not, there's a lot of reasons. And we're going to go into some of those, some of the barriers. But this is where I think what we really want to focus on is how do we get past this? So there's lots of barriers to having this conversation. There are barriers for the patient, there's barriers for the caregiver, and there are certainly barriers for the healthcare team. So oftentimes the patient doesn't want to talk about it because they're afraid. People will often ask me, Doc, what's my prognosis? And I always look at them and I say, what exactly do you want to know? What is it that you're looking for? Because that's a word, but that word doesn't mean the same thing to everybody. So understanding, this fear of their prognosis, what's their prognosis, and really understanding what it is that people want to know. Is it a fear of how much time they have? Is it a fear of how they're going to, what it's going to look like, how they're going to feel, how are they going to suffer? There's a fear of death and dying. Certainly people will be afraid of that. But I can tell you that the even bigger fear that people have is a fear of being in pain. Many people will tell me, I'm not afraid of dying, I'm just afraid of suffering. And people are certainly afraid of being a burden to their family. They're afraid of, and that can be an emotional burden. They don't want to linger, or it could be a burden, I don't want to leave them. Either way, these are hard discussions to have. There's a fear of disappointing their family, of giving up. I hate that term, giving up, because I've never met a cancer patient who gave up. Everybody I know is that you need to live your own life, and how you do that, whether that's with the cancer therapy or without the cancer therapy. Neither of those are giving up. It's living your life, just like Celeste discussed. She talked about the trips and the anniversaries and all of the things. There was no giving up at any time there. There can be a fear, patients avoid it because they don't want to shift the care. They don't want to shift that goal. People are coming in every 2 weeks, they're getting their FOLFOX, they're doing their treatment, and they kind of got a rhythm going, and they know that if they bring this up, then something might change. And they just want to stay with what they know, stay with what's secure. And believe it or not, I've heard from people that they worry about the healthcare team, that they're going to disappoint us. We're trying to help them and our treatment's not working, and they're going to disappoint us. And I'm surprised to hear that people feel that way. I was very glad to be made aware of that, because I can tell you that we are not feeling that we're going to abandon anyone. So caregivers as well want to avoid the topic. So sometimes it's to protect the patient, and I see this a lot. The patient doesn't want to worry the family doesn't want to worry the patient, and nobody's talking about anything because everybody's trying to protect the other person. It's all coming from a place of love. And but what happens is that there's nobody having these conversations and taking advantage of this time. And that's something that I'll tell people a lot. I don't know how much time someone has, but how you spend that time is the only thing you have control over. These cancers, we try to control them. And there comes a point where we don't have control over the cancer, but you have control over how you spend your time. And it's so important to hang on to that and to use that to your advantage. And then we certainly see some cultural reasons why people won't tell somebody about that they're dying, or even that they have cancer, or whatever it might be. There's reasons people, again, it's comes from a place of protection. So then for the healthcare team, I will tell you, and I'm sure anybody who's been in healthcare will not dispute this, in some cases there's a lack of training. The doctors are, there's a lot of doctors that are not well trained in having these difficult conversations. So there's training that's involved, but in addition to training, there's practice. How do you guide someone through this? How do you help someone? You have to meet them where they are, understand where they are in this thought process, and help to kind of push it along and open it up and get people to go a little deeper. And that takes skill and it takes practice. And as in medical school, I can tell you, we don't get a lot of practice on that. So it's just like, having these conversations, I always compare it to a skill like taking out someone's appendix. If you don't do it enough, you're not going to be good at it. So you need to practice. It is a learned skill that needs to be practiced and mastered. And some people have a knack for it. Some people, they're very empathetic. They can connect with people. Some people don't connect so well. So we hope that people find their place in medicine where they can best serve the community. So some of the healthcare team, they may be afraid of it. They're not comfortable with it. They don't feel like they have the skills, or they don't have the skills. Some fear that they don't understand, how much can I say? They don't want to disappoint the family. And this happens quite a lot. There are people that don't always like what I have to say, and I get it. I try to be as empathetic as possible but also honest. And I have people come to tell me they come to me and they say, yeah, I hear you're honest. You're gonna, I kind of have this reputation for telling it like it is, because I think people have a right to know. And I think people are intelligent. And if they know what they're up against, I think it's only fair so that you can decide what to do with your time. But not everyone feels that way. And some people will feel like they don't want to disappoint them, or the family's going to go off and find another doctor somewhere. That's okay. If they learn something out of your conversation and they take that information to their new doctor, at least there's progress being made. What's next? So the other thing is lack of time. And I hate this. I think it's a cop-out, but it's true. These conversations take time, and it is not one conversation. It's a process. You talk to somebody, you introduce this. The next time you talk some more, maybe they go home and they talk with their family. You bring your spouse when there's no COVID restrictions. And this is an ongoing conversation. And the thing is, one of the hardest thing is, when do we start this? When should I have this conversation? One of the things that I often do when I have a new person that I'm seeing is I take it all the way through. Here's where we are right now. We're going to do this, all these active things we're going to do about the cancer, but then it's going to grow. And then we're going to do this, and we're going to get to a point sometime in the future where cancer therapy is just not going to be the right thing. It's just not going to be it's not going to be helpful. And we're going to have to rethink what direction we're going to take and what are our goals that we're going to meet. So people hear it once, and then maybe something changes along that path, and then they hear it again. And it takes a couple of times for people to understand just what is this process we're talking about? What is this conversation? But to really understand how to address using your time wisely, understanding what your beliefs are and your values and your goals. So there's a saying where it's never too early until it's too late. And that's what happens oftentimes, that it ends up that we're having these conversations when somebody is really far advanced and they lost the time to make these decisions. Anyway, so it takes time. This takes time. It's a process. It goes on through the whole diagnosis. So as a result of all these barriers, the patient barriers, caregiver barriers, physician barriers, there's a big mismatch between what somebody's preferences are and what actually happens. There's most people will say, like 70% of people say, I want to die at home, but most die in the healthcare setting. 70% of people die in a healthcare setting. Now that healthcare setting might be hospice, or, you know, it might be something that is aligned with their goals. And sometimes dying in the hospital is the right thing. There have been plenty of times where somebody is at home and maybe they're having pain, or they're short of breath, or it's just getting too much for the family. And if the family's turning into these round-the-clock caregivers rather than their family, maybe they need to come in where they're paid round-the-clock caregivers who can take care of somebody, and the family can just be the family. So I don't think dying in a hospital is necessarily a bad thing. Now, I hope there's nobody from an insurance company on here, because they would probably not appreciate hearing that. But there's times where it's certainly appropriate, where that's the place. People are more comfortable and they're more able to get the care that's needed. So I don't dismiss that. Now, I want to show you a little video of one of these conversations, and this is a parody. So please don't take this seriously, because this is what not to do.
You ever seen the movie The Other Side of Darkness? No. It's about this woman in a coma. Well, I couldn't finish watching it, so I want you to read this.
I, Cosmo Kramer, having just seen the movie The Other Side of Darkness, and not wanting to be in a coma like that lady in the movie, hereby want Jerry Seinfeld to remove my life support, feeding machine, lung blower, etc., etc., etc.
Can you do that for me, buddy?
Well, I don't know if what you have here constitutes a legally binding document.
Well, I'm gonna type it up.
Yes, well, of course, but even so, you may want to talk to a lawyer.
Well, Jackie Childs, he put a restraining order on me. I'm not allowed within 200 feet of his office. I couldn't even give him his Christmas present. Did you take this out of the garbage?
Yeah, it's still got some spring in the strings.
Jerry, this is a piece of junk. How are you going to be the executor of my living will? You see, you can't let go.
Trust me, Kramer, given the legal opportunity, I will kill you.
I wish I could believe you. Hey, Elaine, do you have some free time tomorrow afternoon?
Me?
Yeah, because you're perfect. You're a calculating, cold-hearted businesswoman. And when there's dirty work to be done, you don't mind stomping on a few throats.
Oh, come on.
Situation number 4. You're breathing on your own, you're conscious, but with no muscular function.
Well, would I be able to communicate?
I don't see how.
I don't like the sound of this one.
Yeah, let's pull the cord.
Yank it like you're starting a mower.
Moving on. You have liver, kidneys, and gallbladder, but no central nervous system.
Well, I gotta have a central nervous system.
Okay. 1 lung, blind, and you're eating through a tube.
No, that's not my style.
Boring.
All right. You can eat. The machines do everything else.
I'd stick.
Yeah, stick. Because I could still go to the coffee shop.
That's right.
All right, so that was just a little lighthearted take on this, but that is not what the conversation is about. Now, granted, at the end, Kramer does identify what is important to him, what gives him quality of life, going to the coffee shop. That was something that he could still do. So there are some truths in there, but for the most part, the really important point I want to get across is that this is not a checklist. It's not, one from column A and one from column B. This is about living well. And if you approach it that way, we're not talking about dying. We're talking about, how do I live well for the rest of my life? How do I live well for as long as I'm going to live? And that's a better way to think about what's important to you and what you can do to live well. And on the back end, you're planning for what is not living well. So this approach, I think, helps. And again, of course, I have more questions. It's usually quite interactive, but so we think about what are some of the things that make your life truly meaningful. And for some people, it may be their spouse, it may be their children, it may be seeing, whatever it is that makes your life, their church, the people. So whatever makes your life truly meaningful. So think about that. Take stock on what is it that makes your life truly meaningful. What can't you imagine living without? So as people age, as they get some illness, there are things that we have to sacrifice. And for some people, there comes a point where you have to sacrifice maybe working full time. And people grieve their job. They grieve the loss of their job that they've committed so much time to. And then perhaps people have to give up the ability to drive or something. So there's all this grief that goes on through a terminal illness when you're thinking about things that you've had to give up. But then you have to think, where's the line? What can I not imagine living without? And that plays into this conversation. What fears do you have about future medical care? So that's another one for you people to think about, like, what is it about future medical care? There are some people, especially through this whole COVID pandemic, where being back in the hospital just scares them. And there are people that will not come in the hospital. I've seen plenty of them in my office, and they're always afraid, if I go in that hospital one more time, I'm not coming out. And they will not come in the hospital. So understanding what is it about your future medical care, what worries you, what are you afraid of, so that you can talk about these things. And then some people are afraid of leaving their family with a big bill. So without thinking about what is it that concerns you, then we can't really address it or make amends for it. And then understanding who or what helps you in difficult times. Where do you get that support that you need? Because none of us go through this life alone. So understanding who or what helps you and really reaching out to them and connecting and being open and honest about what's important. So one of the first things we have to do when we think about who helps you is choosing a healthcare power of attorney. That is one of the most important things you can do, and everyone should have one. Anybody 18 or over should have a healthcare power of attorney. If you're less than 18, your parent is your healthcare power of attorney, your parent or guardian. But if you're over 18, then you need to assign somebody that you trust to be your healthcare power of attorney. So it's got to be somebody who knows your wishes, knows what's important to you. Somebody that can act on your behalf. So I have met people where they don't have their spouse as their healthcare power of attorney because they think it's too overwhelming for them and it's going to be too much. And instead, maybe they ask their adult child to do it or something, or a friend or somebody else. So it's got to be somebody who can act on your behalf. You're going to ask them to do things. We're going to go through it. So it's got to be a person that can make decisions in a time of stress. So the healthcare power of attorney is going to be the person that's going to speak for you if you're not able to speak for yourself. So that's usually under stressful times. And it always helps if that person is accessible. Granted, these days you can have a healthcare power of attorney who's across the country. We could do that. We do that now a lot through video messaging and things, but they just have to be accessible somehow. Okay, so if somebody does not have a healthcare power of attorney, then the Illinois State Healthcare Surrogate Act kicks in. And this is an order of events where somebody is assigned the person to be responsible for the patient. So the first level is the patient's guardian, if somebody has an assigned guardian. So second is their spouse. Third is an adult child. Fourth is a parent of the patient. Fifth is a brother or sister, and then we get into grandchildren, close friend, or a guardian of the patient's estate. Somebody gets assigned. So you go through this list, and we do this if somebody does not have a healthcare power of attorney. We have to identify somebody who's going to be responsible and speak for the person. So this healthcare power of attorney has a number of powers granted to them, and they need to be taken seriously. One is that they are going to be the person who's going to decide to accept, withdraw, or decline treatment, including life and death decisions. So these may be things like whether to be intubated, whether to undergo CPR, whether to have a surgery. So if somebody's unable to speak for themselves, then we're going to turn to that healthcare power of attorney and work with them to help make the right decision for the patient. And that's so important. They're acting on the patient's behalf, not on their own behalf, but on the patient's behalf. They may be the person who's going to be responsible for agreeing to admit or discharge from a hospital, a nursing home, and these can be, tough decisions to make. They will have complete access to the medical records. And in the event that the person dies, they're going to be the one who's going to carry out the plans for disposition and cremation. So preparing your healthcare power of attorney as best as possible is always wise. So what you're doing is you're giving them the instructions. Here are the instructions. This is what I want done. And you're counting on that person to carry them out. You really want to relieve them of as many decisions as possible. And you're asking them to carry out these instructions from you. So some of the things to consider, there are medical treatments that may come up. And one of them is CPR. And that's what you always hear about. Would you want to be resuscitated? And that when somebody says that, when I hear, medical student or a resident or somebody saying that to someone, I'm like, that doesn't mean anything. We're going to talk a little bit about CPR in a second. But that's something that in an emergency, there's not a lot of time to think about it and talk and to ask that question. You kind of need to know ahead of time. So for most people, we don't know ahead of time. It's something that happens suddenly. But if somebody has a terminal illness or, we see this frequently in people with lung cancer. If they have longstanding COPD and now they have lung cancer, the chances of them surviving a sudden event is very low, and they need to know that. So ventilation is another one. A lot of us have heard about ventilators these days, and this is, people are on a ventilator, hopefully for a short time, to help somebody get over some illness. But if somebody has an illness that they're not going to get over, then the ventilator is buying time, and that counts. That's what we need sometimes. Sometimes people need to buy some time to gather family and to make sure everybody that needs to be there can be there, and that's okay. So all of these decisions, these emergent things, none of them are right or wrong. It's just whatever's right or wrong for you. Oops. Hang on, not ending yet, sorry. Okay, so how do we make these decisions? More questions for you. This is something that I use every day. And before I saw this structure, I was kind of doing this, but not really understanding that there's a true structure to this. It was just something that made sense to me. And then this is actually a tool that's used frequently. And you think about, would undergoing CPR, for example, help to meet your goals of living well? So you start by understanding what is living well. And then we think about what these interventions will do. What part do they play? Now, when I say I use this, not realizing it, I use this when I talk to people about chemotherapy. Would undergoing this, round of chemotherapy help to meet your goals of living well? If I'm not curing the disease, if I'm helping people to live longer and to live well and to, see their new grandchild, to see somebody graduate, whatever, we have to think, is this therapy going to help to meet those goals? What outcome do you expect from whatever? What outcome do you expect from CPR? Most people, if they have a heart attack and they're getting CPR, they're expecting to get better. And this comes up with any sort of treatment. When we're doing the advanced directive, if we're thinking about artificial nutrition, what do you expect from artificial nutrition? If somebody has a cancer that's growing, their metabolic requirements are so high that no amount of nutrition we pump in is going to help them to build muscle mass and to get stronger. So if that's what their goal is, that's probably not going to happen. But if their goal is they want to maintain, then maybe we can do that with artificial nutrition. What's an unacceptable outcome? And this is the part that is really important. When I'm ordering chemotherapy for somebody, I'm always thinking in the back of my mind, what's the worst thing that can happen? And if the worst thing, and then what's the chance that it's going to happen? So if the worst thing is that can happen is that I can make them sicker with their chemotherapy, or they could die from their chemotherapy, then I have to think about what are the chances that's going to happen and make sure it's worthwhile. And this would apply to anything when we're doing an advanced directive. And what fears or concerns about making the decision. So again, understanding what are the fears, what are the concerns? Is it that one of the things that I know happens, if people say they would not want CPR, they're afraid that people are going to withdraw all sorts of help and support. And if that's the fear or concern, then it's important to voice that and to make sure it's clear that no, I don't want chest compressions at the time that I die. but I do want antibiotics and I want to be kept comfortable and I want all of these other things to be done up until then. And that's what we generally do. But people are afraid that if they say DNR, do not resuscitate, that it's hands off and we don't give them any other care. And that's not true, but that's a fear that a lot of people have. And I think it's important to voice that. Okay. So I said I was going to come back to CPR, and it's just because CPR, when we see it on TV, people get CPR, they do the chest compressions, and then, you know, the person's maybe in the hospital with the oxygen in their nose, and then they go home. And that's the minority of cases that we see. Fewer than 1 in 5 people who get CPR while they're in the hospital. This is a study that was done on hospitalized patients. And that's important because we're talking about people who are in the hospital for some other reason. So they've got some sort of illness. This isn't the guy who's running the marathon that we see like every year that has CPR. This is somebody who's in the hospital for some reason. And it's less than 20% of people that actually leave the hospital after about 2 weeks. So very few people that are sick and have a heart attack and get CPR actually recover from it. And of those who survive, 30% of them often need to go to a nursing home or a rehab facility. And that may be fine, but for some people that may not be fine. That's where you have to identify what your own values are. There's some people that say, I never want to be in a nursing home. And then sometimes there's other folks that are like, oh, rehab, I'm doing okay. I'm getting the attention, and then with a hope to go home. And then if you look at older, weaker people that are living in a nursing home that are not living independently, essentially very few will survive CPR if that was used at the time of their death. All right, so what's an advance directive? An advance directive is a legal document. The advance directive goes into effect only if you're incapacitated and unable to speak for yourself. As long as you can speak and make your own decisions, then you are making your own decisions. But if something were to occur and you're unable to speak for yourself, then we turn to the advance directive and we identify who is the person that's designated to speak for you. Now, one of the ways that you can think about this, so for people who have no medical problems, we still want them to get an advance directive. Why is that? Because the biggest thing that occurs to people who are like in their 20s is some sort of a traumatic event, a car accident, right? And somebody has neurologic compromise, they can't speak for themselves. They need to turn to somebody who can speak for them and say, what are we going to do? So I think it's really important for everyone to just have this document stating what they would want. Now, so this could be the result of disease or severe injury. So no matter how old you are. Now, what is an advance directive? We're going to get to the actual details of it in a second. So we think about this as a living document. It changes as your life changes. So if you have an advance directive when you're 20 years old and it's assigning, say, your parent as your healthcare power of attorney, and you're saying, yes, I want everything done at the time of my death to keep me alive, then that may change as you get older. And as you get older, you might now be in your 50s. So your parent now has dementia and you don't want your parent as your healthcare power of attorney. You're going to assign your oldest child. And it goes on. And just like your financial plan changes as you get married and you have children and they go to college and then you retire and all of these things, your advance directive changes. It's a living document. It changes as your health situation and your social situation changes. So what's an advance directive? There's 2 parts. There's the living will. The living will states, if something were to happen to me, this is what I want done. And then the power of attorney for healthcare, which we talked about, the person who's going to speak for you, because we can't predict everything that's going to happen. So when we say, to say that this is what I want done if something happens, but we can't predict everything. So we can give some ideas. If I was, if I'm unable to interact with my surroundings and not expected to get better, then this is what I want. If we can come up with all these scenarios, but we're never going to get them all. So you need somebody who knows you, who knows what you want, knows what's important to you, knows what your beliefs and values are, and can be your voice and speak for you. So there are other documents that go with this advanced directive. There's a DNR order, there's a POLST, there's you can set up ahead of time to have organ and tissue donation done. There's all sorts of things that you can put in place so that you get the care that you want and you relieve the burden of your loved one so that they don't have to make those decisions. So these are some of the documents. This is a living will, and these come right off the internet. This is the healthcare power of attorney. This is what I think is the most important one, and I'm going to spend a couple minutes going through. The 5 wishes is another one. This covers a lot of the things of the power of attorney, but it goes into a lot more detail about a lot more emotional and psychological and spiritual issues as well. And then this is the POLST. This is a physician's order that states do not resuscitate, do not intubate, comfort measures, do not do any invasive care. So all these things, it's signed by the physician. So it's a physician's order, which you can have, and you have these at home. And so if something were to happen, this physician order works at home. And that may not seem like a big deal, but it was a big deal because it didn't used to be. It worked in the hospital. So if something happened in the hospital, you could get what you wanted. But if you were at home and somebody called 911 and the paramedics came in, they were going to resuscitate. So now there's a physician's order that states, I don't want resuscitation in the event of my death, at the time of my death. Or I do want an attempt at resuscitation. So you get to call the shots. Okay, here's the healthcare power of attorney, and I'll try to be brief with this. It's very simple. You can print it off right off the internet, and it's a legal document as long as it's filled out properly. You put your name in it, your address, you name your agent. You put the agent's address, the agent's phone number. This is the person that you're relying on to speak for you. Here are the things that we went through that your agent is going to do. Your agent can make healthcare decisions, including, and these are the ones we already went through, the declining therapy, discharging from the hospital. They'll have access to your medical records. They'll carry out the plans that you've already made at the time of your death, for your cremation or burial or whatever it is that you have decided. Now, you can decide if that agent is assigned as of right now, or only if you can't make decisions for yourself. Why would anybody do this? So there are times where maybe somebody has dementia, and dementia is a tough one because it can wax and wane, and then there can come a day where they're not capable of making decisions. And it is so important to have this healthcare power of attorney in place so that you can assume those decisions that are so important. Because if you're trying to do this with somebody who's still alive and not not able to make that decision, it can get a lot tougher. So sometimes then if somebody has dementia, they'll say, okay, make the decision now. Or I've had people who are very hard of hearing and they don't have the equipment needed to hear on the phone. So they always say, call my daughter. Call my daughter, and they want their daughter to be making these decisions. So there's reasons why they would, but for the most part, most people make the decisions at the time that I can't. So then this is the living will part, and this is optional. You don't have to do this on here, but this is where you say the quality of life is more important than the length of my life. So then it's got all these things. If I'm unconscious, I'm not going to get better, then I do not want life-sustaining therapy. Or staying alive is more important to me no matter how sick I am, and I want every opportunity. And you can select this, or this can come later in a different document, or you can just rely on your healthcare power of attorney to know what you would want. You can put in limitations here, like I don't want dialysis, or I have an organ donor card, or whatever it is. You can put information, and then you sign it and you date it, and that is a legal document. Okay, so what do you do with it? You keep the original. It's your document, and it needs to be someplace where people can find it, because these things always happen, in emergencies. So when my dad was sick, they always had it right by the door. And when my mom would take him off to the hospital in the middle of the night, she would grab the healthcare power of attorney and bring it with. So these things need to be accessible. You give a copy to your healthcare proxy, to the power of attorney person, and maybe an alternate. There is a place I didn't show you where you can put alternates, and you can give it to your alternate as well. You should have a copy Give it to your doctor for your medical records, but do not rely on your doctor to be able to find it when you need it. That's why you need to keep your own copy. People take much better care of their own records. Now with everything electronic, we are much better at sharing a lot of this information. But these things, I can tell you right now, they're just scanned in the chart with a whole bunch with your CBC and all these other labs and all this stuff. So we're not perfect yet. And we're still working on it. You should tell your key family members and friends where you keep it. Keep a book by the door with your healthcare power of attorney and important numbers. And I will just throw out there your logins and passwords for important websites that you visit. All of these things, that's a topic for another day. Okay. Okay, other advice for managing it. This is my last slide. So you need to, it's important to review it. Like I said, it's a living document. It's going to change as your life changes. So it's important to take a look at it every 10 years or so and make sure it still says what you want it to say. If you want to change it, you tear it up. You just have to make sure you get all the copies that you gave out, that you shared with the alternate and with everybody else. So what I tell people to do is they take their healthcare power of attorney. You have the original copy. On the back, you have a list of everybody you gave a copy to and the date you gave it. So if you decide to change it, if the person you put as your proxy maybe isn't able to do that now, then you need to notify all those people that you have a new healthcare power of attorney. Whatever is the most recent dated one is the one that works. Also, if your life changes, you know, if we did have one of our docs come in the ER and he was sick and people said who's his healthcare power of attorney, and we looked it up and it's his ex-wife who he never changed it and none of us wanted to call her. So it was, you know, it's important as your life changes that you make the adjustments. And if your proxy is not able to do it anymore, it's important to relieve them of that if they're not able to, because it's a big lift. It's an important thing that you're asking them. So that is the advanced directive, what it is and how you manage it. And I am available for questions after, I believe.
Yes. Thank you so much, Celeste and Dr. Mulcahy. Celeste, thank you especially for sharing your experience. What a beautiful way to honor Lou's memory. And I look forward to talking with both of you again during our Q&A section. We've had a lot of great questions coming in, but before we get there, let's talk with Priscilla Andrews, who is the clinical manager from Cancer Wellness Center. Welcome, Priscilla.
Now we know it's a Zoom meeting.
There you go.
Erin, thanks for having me here this evening. Hello, everybody here with us tonight on Zoom and on Facebook. My name is Priscilla Andrews, as Erin mentioned, and I'm the clinical manager here at the Cancer Wellness Center. Just a little context for who I am. I'm one of the therapists at the Cancer Wellness Center. I'm a licensed clinical professional counselor. I work with people through our counseling program, with individuals, couples, and families, and also have a history working with our support groups here at the center, both patient and caregiver groups, and then also spousal bereavement groups. So I am here today, and I'm going to go ahead and share my screen to talk to you a little bit about what happens next after you know, you hear Dr. Mulcahy talk about those directives, and you heard Celeste talk about what that personal experience was to make those end-of-life decisions. And I'm here to talk about, you know, the difficulty, the challenge of coping after all of that is done, after there's no more treatment, after there's no more options, and your loved one has passed away. And I'm hoping that today, you know, I don't know exactly who's in the room with us tonight and might be viewing it, so can appreciate that maybe some of you have a loved one who's still in treatment. Maybe you're here to get information about what it may be like when things progress. Maybe some of you have somebody who has progressed illness, and perhaps some of you are here in the room with us tonight having lost a loved one. So hopefully today, regardless of what your loved one's status is, that you can take away from my presentation just some information that will help you either conceptualize what you may anticipate or what you may be experiencing, and hopefully take away some coping strategies that maybe will help you when you are in the grieving process, or may even be helpful for you when you're in the anticipatory grieving process. So what do I mean by that, right? So grief is a normal process that we go through when we lose something or somebody. It's the way that we heal from the hurt of that absence. And there are so many different things that we grieve. I think most commonly we think about grieving a person, right? Or maybe a living creature. We can think about grieving a pet. But I think there are other things that are grieved along the way across the cancer trajectory that are also losses that can sometimes be seen or unseen, right? Perhaps losing one's role in the family, or perhaps one's freedom because of caregiving requirements. We can also think about losing an envisioned future. You know, if you have a loved one where you had ideas of what retirement was going to look like, or you had ideas, I think Celeste made the comment of, getting married and planning for children and being excited about building that home together. And of course, hearing Celeste, you speak about appreciating that time and celebrating those anniversaries, and also, that loss of what you thought life would be like. And so when we think about loss, we can think about it happening in multiple ways, not just after the death of a loved one. It's a natural response that we have. And there are lots of different signs and symptoms that we experience when we're in the grieving process that happen across multiple domains. Right? We can have physical signs, emotional signs, behavioral signs, cognitive signs. It's typical for us to have signs and symptoms in each of these domains. And I sort of like to think of it, if you think about back in the day when you'd have like a tuner on your stereo, and there'd be all those little different knobs that you could turn, that you could adjust, what the levels were. That's how these signs and symptoms are. So the signs and symptoms that you may experience that are reflective of your grieving process can be very different than other people, can be different from other people who've experienced a similar loss, and can be different from the other people that have experienced the same loss, right? So, one of the challenges that can come up during the grieving process is, you and your family members may have lost the same person, or maybe as your loved one is progressing in their illness and you and your loved ones are watching that same person sort of fade away from you in different areas of your life together. The way that you respond to that, the way that you show that grieving process are going to be different. And I think one thing that I want to highlight here is the fact that there is this physical experience of grief that can often catch people off guard. The physical fatigue that can come along with that, the chest tightness, the shaking, the changes in appetite, right? Some of those things we don't always necessarily know to associate with the grieving process until we're in them and we're experiencing them, and we can be a bit caught off guard. Now, you heard me mention anticipatory grief, right? So anticipatory grief is also a normal process that we go to when our loved one is still living, but we are anticipating their death. It's a very common occurrence when you have a loved one who has a terminal illness, when perhaps there has been discussions like Dr. Mulcahy mentioned around prognosis, and perhaps your doctor has given you a number. Sometimes you get that, right? There's a 6-month prognosis, there's a 6-week prognosis. But that anticipatory grief can also come along with when we don't even have a number. There is no time frame, but we know that there is an eventual death that is going to come with the illness that our loved one is facing. And you can see here some of the signs that come along with that anticipatory grief that mirror what we experience from a grieving process after we've lost that person. I will say, I think one of the challenging things that comes along with anticipatory grief is that people that I work with, they often feel like because they have started grieving the loss of that person before the person died. Number one, sometimes there can be guilt associated with that because they are feeling the pain of that person not being there, even when their person is still there. But that's a normal experience to have, because even as you're anticipating that loss, you may be thinking about what life is going to be like without that person. I think alongside of that is, I think there are people who it's not uncommon that because they've grieved while the person was ill, that when the person dies, they can be caught off guard that the grieving continues. So both the grief before the person dies and the grief after the person dies are normal response and experience when we're dealing with somebody who is either terminally ill or who has passed away. So I want to say that I hope that tonight, if you take nothing away from my presentation, is that hopefully we'll leave having the myth of the 5 stages of grief debunked. So I think probably most, if not all of you, have heard of the idea of the 5 stages of grief. It's a very well-known model that was developed by a physician. Her name was Elizabeth Kubler-Ross. She actually did her early research at University of Chicago. So shout out to a local well-known person who started the study around the dying process. And in 1969, she published a book called On Death and Dying that outlined these 5 stages of grief: denial, anger, bargaining, depression, acceptance. Right? And that sort of set us up with this idea that there is this linear process that we go through, that we move through each of these stages sequentially. And that the idea was that this applies to the person who is grieving. But that's not so. Elizabeth Kubler-Ross's research was really around the experience of the dying person. Because when she started her research, people were not talking to the person in the hospital that was dying. I think, Celeste, you mentioned the fact that, there was an avoidance of eye contact at times when even the healthcare professionals were talking to you and your family about what was going on for your husband. And that was even more pronounced back when Elizabeth Kubler-Ross came on the scene. She was a psychiatrist, where they would put the dying person in the back room at the end of the hallway. So she was interested in trying to understand what that experience was like for them. But now what happened is that got applied to what it is like for the grieving person. And that just doesn't tend to be the case. It's not to say that people do not experience denial, do not experience anger, do not experience a certain amount of feeling of wrestling with, if I could only have that person back, or depression, or reach a point of acceptance. But there are many different theories around what the grieving process entails. And one of the kind of most succinct ones that I think is helpful to sort of reconceptualize what the grieving process is like is called the dual process model. It was developed in the 90s by Margaret Stowe and Hank Shute. And really, it basically boils down to 2 concepts, which is we have 2 tasks that we have to accomplish after we've lost somebody. We have to feel the pain of the loss, and we have to figure out how do we move forward without this person physically present in our life. And we have to be able to do both of those. And as you can see, those kind of lines moving back and forth, the idea in the dual process model is that we are always oscillating. We're vacillating back and forth between ways of coping and activities and behaviors that allow us to feel the pain of the loss, and that we are also moving towards activities, behaviors, and feelings that help us figure out how do we move forward in this totally brand new world without this person in it. And when I talk to people about this, I sort of prompt people to think about, are you a feeler or are you a doer, right? So what do I mean by that? So and I want to say that what I'm about to talk to next is sort of like a very broad idea to just sort of get you thinking about what is your more instinctive tendency. It doesn't mean that feelers don't do anything that is not restoration oriented and that doers don't do anything that is loss oriented. But you can think about what your natural proclivity is, right? So feelers, people who are more loss oriented in their way of coping with loss, they tend to focus more on the thoughts and feelings, the things that are associated to the grief and their pain of that loss, right? So they focus on the things that can provoke those feelings of sadness, loneliness, and anger. So what might that look like? People who are feelers may spend more time thinking about the person who's died, may spend more time engaging with mementos, right? So having lots of photographs out, looking through photo albums, watching old videos, keeping clothing around, maybe even sleeping with articles of clothing. They may be more likely to feel comfortable talking about memories of their loved one, or may feel more likely feeling comfortable bringing up their loved one. It may also be more difficult for them to focus on activities like current daily activities, and you may be less likely to plan and accept social plans or to plan for pleasurable activities. Now, doers, on the other hand, right, they likely focus more on those activities related to daily life that can distract from grief, right? Doers tend to work to ease the pain of grief and focus on things that can take away that pain. So they're more likely to make those plans. They're more likely to accept those invitations. They're more likely to take on challenging tasks to keep their mind occupied. You know, maybe they're taking on tasks at work or tasks at home, projects at home. They may have an increased ability to be distracted away from their feelings and focus on those activities. What can sometimes come along with that? And again, this isn't a like black or white thing. This is just for you to think about what you tend to lean towards. There may be less comfort in bringing up memories of the loved one, or even having other people bring up those memories. And they may also spend less time engaging with those mementos. So what does this tell us about how do we cope with loss? Well, what it tells us is we need to do both, right? We need to both feel the pain and spend time engaging with those emotions, the loneliness, the sadness, the anger, the yearning. There's research that shows really the predominant emotion that comes along with loss and bereavement is yearning for that loved one. And we also have to have time that we have and activities that we do that help us figure out how are we going to move forward with our life. So if you identify more with being a doer, what you need to think about is how can I focus on increasing the loss-oriented activities in my life? And if you tend to be more of a feeler, you need to focus more on what are the restoration-oriented activities that I can do, the things that are going to help me start thinking about how to move forward. So what are some of those activities that we can do? Now, I will say I'm going to kind of go through these in the interest of time. I'm going to go through these quickly, but don't worry, because as I think the moderator put in the chat, you're going to get a handout that has all of these things listed, because this is the densest part of information in my presentation, right? So what can we do that is loss oriented? I mean, the number one thing is if you find that you are a doer, that you are focused on how do I numb out, how do I take away, distract away from the pain. You know, perfect example of this is I had a client once that after he lost his wife, he woke up, he went into the office early, every night he planned something to do. He came home and fell into bed exhausted and just kept doing that over and over again until honestly he couldn't do it anymore, because nobody is the Energizer Bunny. So if, you know, that's sort of a very extreme case of somebody who was restoration oriented, but sometimes we have to set aside some time to grieve. It's also helpful to think about how do we practice first aid for difficult emotions. So what does that mean? That means to accept whatever you're feeling, identify what you're feeling and being specific, right? Not just that I'm in pain or that I hurt, but I'm feeling angry, I'm feeling sad, I'm feeling lonely. And then figure out, what can I do with that feeling? Do I need to write it down? Do I need to cry? Do I need to yell? Do I need to beat a pillow? Do I need to find somebody that I can talk to who can listen non-judgmentally? It can also be helpful to develop rituals to help you remember and pay tribute to your loved one. This can be things like lighting a candle. It may be even talking to your loved one. It can be things like planning visits to visit the cemetery or a shared place. Some people also can have more annual rituals, like participating in a fundraising event. You know, you've heard people comment, and Celeste, I know I keep mentioning you, so shout out to what you shared before me, you know, that being here may be for Celeste a way to honor and pay tribute to her loved one. So there's lots of different ways we can think about keeping that person alive to us, even if they're not physically here. Sometimes it can be helpful to journal, to write things down. That can be meaning in a book that you keep, or it may be writing something down on paper or in your computer and then deleting it or throwing it out as soon as you're done. There are also, if you look up online, you can find lots of different grief journals that will have prompts in them. In the handout that you're going to be getting from me, there's a link for a free journal that you can download that has like daily prompts or weekly prompts that you can fill out. Sometimes it can be helpful to write a letter to your loved one. That could be a free write, or sometimes finding prompts that can help, you know, I'm saying goodbye because saying goodbye makes me feel X, you taught me this. This can be especially helpful if maybe you didn't get to say all the things that you wanted to say, or if there were things left unresolved in the relationship. Sometimes we can think that if we had a difficult relationship with a person, that it will end up making the grieving process easier. And sometimes that is true, but oftentimes that can be challenging in a different way, because when we have unresolved issues in a relationship, you know, the ideal way to resolve them is with the person that you have those issues with. And after somebody dies, they're not there for you to figure out how we're going to make that relationship better. So writing a letter to them can be helpful in those times. Also thinking about visiting places meaningful to you and your loved one, listening to music that was meaningful to you or your loved one. And then, of course, sometimes it is a matter of seeking support from a professional, a therapist, or perhaps a spiritual guide like a rabbi or a priest or a pastor. Now, on the other hand, there may be restoration-oriented activities that you need to sort of complement what your intuitive way of coping is. You know, so taking the time to plan fun or satisfying things to do. Oftentimes that can be difficult because there can be some guilt associated with that. However, it is something that's going to be necessary to help balance out and move through that grieving process. Taking care of yourself physically, exercise, healthy eating, sleep hygiene. It can also be helpful to identify what are your strengths and resources. You know, what capacities do you have, ways of behaving, thinking, and feeling that are authentic and help you function at your best, right? Things like gratitude, social intelligence, humor. These are things that you may be able to lean on as you're working through your grief process. Resources can be things, but they can also be people. You know, are there people in your social network that you can turn to when you need to find some way to be distracted from the grief, when you need to have a good laugh? It's also helpful to identify what your roadblocks are. So research has actually shown that people who, I skipped over values, I just realized that, but I'll come back to that in a minute. Research has found that people who are good at identifying potential roadblocks that they're going to encounter tend to be the most hopeful, right? So that may be anticipating, what is it going to be like for me to go to that first family event without my spouse? You know, what is it going to be like for me to attend that college graduation or go to that wedding? Going back to values, you know, thinking about what is it that is meaningful to you in your life? What has been meaningful for you in your life? And can you start intentionally doing things to put those values into practice and to live those values? For some people, it is important to limit or remove or even dispose of reminders of your loved one. So getting rid of medical supplies and medications, perhaps going through and curating which photographs you keep on display of your loved one, or when it comes to your loved one's items, storing them away, or perhaps finding a meaningful place or people to give them to, just so that they are not these triggers in your environment continually bringing up those thoughts and emotions associated with the loss. On the opposite of listening to music that maybe was shared with your loved one, there may be music, food, activities, programs that you enjoyed that your loved one did not, especially if it's a partnered or spousal relationship. And so turning to those activities and things that are enjoyable, again, in an intentional way, can be helpful to provide a space of relief in the sea of pain that comes along with loss. And again, just as much as people who are doers may benefit from seeking out support, professional support, so can people who are more feelers and more focused naturally on loss-oriented ways of coping. Lots of services available at the center that can be helpful to you if you are needing more professional support. You'll also see that there are offerings here that can support that mind, body, and that physical wellness piece that I mentioned. If you have a loved one who is currently dealing with a pancreatic cancer, is still in treatment, we have services for you, support groups for caregivers, for spouses. We also have patient survivor groups. Also want to give a shout out to our Pancreatic Cancer Networking Group, which is in part supported by the Rolfe Foundation, that meets monthly and allows people to meet with other family members and other patients who are dealing with a pancreatic cancer diagnosis. And there are services here at the center beyond your loss if you're needing that extra support. I think I want to also say that for both doers and feelers, it can be helpful to anticipate difficult times, right? And there are these predictable times that we know are going to be difficult. Birthdays, anniversaries, family events, the anniversary of people's death or their yahrzeit. I think also thinking about those milestones related to the illness can sort of sneak up on us. And even if we're not consciously aware of that, there's a deeper part of our brain that stores that information that can cause us to respond with those grief reactions and those signs and symptoms and catch us off guard. So if we can be conscious of the fact that these may be times when we need to grant ourselves some grace and have a little bit more TLC, it's going to help us find our way through that. And part of that is taking care of ourselves, doing the things that are going to help us ease our pain. That may be planning something fun or satisfying to do, something to do with other people. It may, for some people, be about taking time in solitude, and also thinking about, are there ways to care for the person who's died? Are these the moments to think about, how can I honor their memory? How can I pay tribute to them, have a ritual in place, have a time set aside to honor their memory and share their memory with other people? I think the thing that I want to end on here too is how important it is to be patient with yourself. Grief takes time. I often say to people, especially those who have a spousal relationship, I see many people who have been with their spouse 10, 20, 30 years, or perhaps they've lost a parent and they're an adult. And if you think about how much of your life, your mind has been oriented to that person being a part of your life, and after you lose them, how brief that period of time may be. And we can get, I think, because it can be so painful to lose that person, and the grieving process can be so exhausting, that we want to get through it as quickly as possible. But if you just think about the cognitive work that your brain is doing to adjust to the idea that that person is not in the world anymore, you're doing so much processing in the background that it's important to be patient with yourself. There's going to be good days. There's going to be bad days, going at your own pace, allowing yourself to heal. And I think also being prepared, as I said before, even if it's the same person you've lost, there's going to be differences on how people react and differences on how people respond to things. So I'm looking at the time. I hope that I gave at least a minute for the panel. My contact information is here. If there's anything you want to reach out to me after today's program.
Oh, thank you, Priscilla. That was really helpful on so many levels. We have a lot of great questions coming in. So I would love to invite Celeste and Dr. Mulcahy to come back on so we can get through some of these questions. Great. Let's jump right in. Dr. Mulcahy, what do people do once the directives are there? You had mentioned the importance of hanging on to copies, distributing. Can you kind of talk through that again? Because that really is an important aspect, I think, of this.
Yeah. So once you work through completing the advanced directive, then you need to make sure that that information is available to the people who need it. So it's very important that you keep the original copy, that is your document. But you make copies, or you bring it to your doctor's office and you ask them to make you a couple of copies, and they file one in their medical record, which hopefully is electronic medical record. So they will want it. You bring that to a doctor without them asking, they're gonna, yeah, that's gonna have a big impact. They want it. And then you give a copy to the power of attorney, to whoever that person is. It's always good to give a copy to maybe an alternate if they're on there. And the last thing that I didn't mention, which I think is important, is that first of all, your children know, or your siblings, or whoever else is going to be at the bedside if something were to happen. Make sure they are aware of, that you've had this conversation and you've discussed this is what you want. And the last thing is a neighbor. So this is what a lot of families are scattered all over the place. And if the paramedics are coming to the house, it's going to be the neighbor who's going to be the first one to know. So it's always a good idea to, let your neighbor in on this. They don't have to be the power of attorney, but just say, hey, this is my healthcare power of attorney. Here's the number. This is who I want you to call if anything were to ever happen to me.
Sure. Okay, now, and Celeste, I want you to weigh in on this piece as well. How do you make sure that your family follows your directives? Celeste, you had mentioned that Lou's family were not ready to follow what he wanted. So can you both talk about that from your specific perspectives and share insights to help our audience today?
Well, from my personal experience, we did try to initiate the conversation with family, and so we would. I always say meet people where they are, and anything, and so we were able to have little bits here and there, but overall it was pretty difficult. However, in the end, where I knew that we were, we needed to get Lou out of the hospital into the hospice facility, I loved the internist we had, and I implored and asked if he would come in and help have the conversation. And I couldn't believe how effective that was. He got our whole family into the room. He was just so empathetic, but also fact-based, and explained to them. And I think I just had too much emotion to be able to do that. And I have to say, he got them on board. So I guess my takeaway here is that I would leave is use resources, and don't take it all on yourself.
Anything to add, Dr. Mulcahy?
Yeah, that was great, Celeste. Thank you. I think you're right. I think the physician, or sometimes it's even a physician you don't even know, it's somebody who's just on duty when this emergency occurs. For the most part, we do, like the physicians in the intensive care unit or on the oncology service or something like this, we're used to dealing with families because this is something that a whole family is going through. So being that person to really be looking out for the patient's best interest and supporting everybody. We're a little bit removed, we don't have all of the background drama of family life. I always tell people families are complicated. There's no such thing as that, leave it to Beaver family. Things are complicated. Everybody's family has, there's complication, and there's no judgment, and there's no nothing. It's just a matter of helping carry people through this very difficult time. So it is hard. And I'm glad to hear from Celeste that that internist was there when they needed them.
Absolutely. And also social worker, some of these little conversations along the way, the social worker, she actually led our support group. So I got very close to her, and she also consistently checked in and gave a lot of attention to Lou's family. And that really helped as well.
That's great. I was going to ask Priscilla, from that point of view, from the grieving aspect, there's a lot of grieving that is attached to that when you don't agree with what your loved one's wishes are. Any insights on helping people through that?
Yeah, I mean, I think I will say, I always have a hard time because I don't want to make generalities, but I think certainly communication can be so difficult. And I think, as I mentioned, people just respond so differently, even when it's the same person involved. And kind of to mirror what Celeste said, I think that idea of using resources, and certainly sometimes it is about having a more neutral voice to help moderate that conversation, that can help diffuse what can otherwise be a fiery conversation or escalate to a fiery conversation. Because I think in the end, it's just that people want to be heard, and everybody is in pain. You know, everybody's in pain. They're just expressing that pain differently. And when we're in pain, it can make it hard for us to really fully be present for other people's pain. And that's why a physician, a social worker, a therapist can sometimes be helpful, so that the conversation doesn't get cut off because one person isn't feeling heard.
Right. Yeah, that's definitely true. I want to take a moment real quick here. I know that within all of our materials, we said we were going to go till 7. It's 7:05, 7:06 now. We are going to push forward because we have a lot of great questions. If you do need to pop off, don't worry. As we've mentioned before, we're going to send out the webinar. We're going to send out the presentations. So please send in your questions and we'll still be able to get to them. So back to having conversations. What happens if there's not enough time for the conversations? And I'll kind of double this one up. What do you suggest if somebody's really resistant to starting the advanced care conversations?
Yeah, so that's two different questions, actually. If you have not enough time. So when I think about that, so that's where we hope, oftentimes there's not enough time. Like if you look at other traumatic things that occur, when something just suddenly traumatic occurs, perfectly healthy person and something occurs. Yeah, there's not enough time. Now, had they prepared an advance directive at the age of 18 and things like that, then maybe they have discussed these things. And we do encourage people to do this. Sometimes there's, maybe there's a movie on and it addresses this. It's kind of a good time to bring up the conversation, or you're reading something in the paper and there's something that comes up, that any opportunity to kind of get people talking about this, I think, is really important, so that we can at least understand what what the spirit of their wishes are. So we can guide people when they need to. So when there's not enough time, that's really hard, because we talk about grieving, and people are grieving just so much, so suddenly. And now they have to make decisions, and they've got, people looking at them, asking them to make decisions. That's why I don't think, and I tell people this, when we're in the hospital, we don't have to do something sudden. We can hold this. It's okay to go to the intensive care unit if we need to. It's okay to be intubated if we need this time to kind of get our head around this, figure out where we are and get a grip on what's going to be happening. It's always hard when things are happening in the intensive care unit instead of in one of these, lovely, calm hospice units. But that's just the way it is sometimes. Now, people are resistant to talk about it. That's different. And there's a balance. Depends on why they're resistant. Sometimes people are resistant because they really can't cope with it. They really can't handle it. And it's hard. And what we have to, if I'm talking to a patient and I understand that they are just not having it, I make sure that the spouse or whoever their support person is aware that we are here and open to this conversation because they need it. And I will share with people, if there's, say it's a couple that perhaps their spouse needs to talk about it. And I will put that right out in the open that I understand you don't want to talk about this, but your spouse might. And, you know, by you having this conversation, it could really help them out. Because everybody, like I said, that they're so afraid, but so many times understanding that they're doing this for someone else can sometimes break through. So,
Can I chime in? Is that okay, Dr.
Yes.
Mulcahy? You know, I think the other thing is like, you know, I don't look at it as resistance. I look at it as people don't feel safe enough to have that conversation. And so part of it for me, and this is in a non-medical setting, I will say, Dr. Mulcahy, I'm not there at in those same moments as you, is, you know, there is something that is making it difficult to have that conversation. There's something that they don't feel safe enough to talk about that. And so that's either going to look like anger and pushing people away, or it's going to look like shutdown. And those are natural responses for any of us to have when we are faced with a danger or a threat. So, you know, I think that's where sometimes it is about getting a therapist or a mental health professional involved to help kind of figure out what is going on for that person. But sometimes it is just having a conversation with that person to like understand what's going on for that person. When we bring this up, what happens for you? And that may be difficult for like a family member or a spouse to have, but perhaps there's somebody else that is a resource within the family that has a very calming effect on the patient, that maybe not in the moment that it's being tried to discuss, but outside of the moment, that person can talk to them, not about the topic, but about help me to understand what happens when we talk about this topic, because there's so much information that can be had. I often talk about with clients, like, have a meta communication if the communication is difficult. So we're not going to talk about the thing that's hard to talk about. We're going to talk about what is it like to try to talk about that topic. And that can sometimes pave the way to talk about, like, what is it like for the person when the spouse brings it up, and what happens for the spouse when the patient says, I don't want to talk about this. And that can create a little bit more safety to start approaching that conversation, because then that person can feel maybe heard and understood around why it's so hard for the topic, and understandably a hard topic to discuss too.
Anything else to add to that, Dr. Mulcahy?
No, I think that was right on. I think that's, yeah, when people are resistant, there's a reason for it. And sometimes it's coping or, you know, fear, whatever it is, there's usually a reason. And I don't try to beat people over the head with it. You know, that's, you just guide them. You guide them to just make sure that they're being heard, that whatever their fears are or whatever their wishes are, that we can meet them.
Sure. And I think one of the most important things of this that each of you said is it's not just one conversation.
Mm-hmm.
It's a conversation followed by another, followed by another.
Yeah. And I really love what you said, Dr. Mulcahy, about like buying people time, right? Because in the immediacy of that, you know, if people are frozen or they feel like they have to act, like sometimes we just need a little bit of time so that we can be in that space to think a little bit more clearly and be able to make some of those really difficult decisions.
Definitely. So we have a question from somebody who their husband was diagnosed with pancreatic cancer at an early stage. I'm going to summarize here. He went through major surgery, had COVID, went through multiple chemo treatments and radiation. And after looking good, things started to decline and he had passed. So she said his last 5 weeks at hospice was extremely helpful. One thing that she had, it sounds like there's challenges. Can you offer advice on how to get on board with somebody else's plan because of your own grief? I think it's a matter of setting aside or working through, I guess we don't set aside feelings, we work through them. Mm-hmm. But what would you recommend on that?
I'm not sure. I want to make sure I understand what this person's asking. So her husband went through a very difficult time. Well, the whole family did. And working through her grief.
Right. She said that that he was worried about her.
Oh, yeah. Yep.
And so
Yep.
working through her grief to be able to follow his ideas.
Yeah, we see that all the time, that people are worried about what somebody else is going through. People talk about being a burden and all of these issues. And it's, again, I mean, that's such an act of love to show somebody that I care about what's going to happen to you after I'm gone, essentially, and reaching out to that. So trying to put aside, I want to make sure I understand, trying to put aside her own feelings so that she can support him, or him putting aside his feelings so he can support her. Either way, we don't really put aside our feelings. You're right. We work through them. But what's my recommendation? Again, I think it's being heard. It's clear communication. And I know for myself, I would probably bring in our social worker, somebody whose specialty is in this area of communication, and make sure that they're working through this, because, medically, there's not anything that I can do to make this happen. I can try and educate them about what's going to happen and things, but I think for the most part, this is something it's all about the communication, so that people feel that that they've been heard, and that there's no regrets. I think oftentimes when you sort of remind somebody that this other person is going to be left, they're going to be the one who's going to be feeling this, that they need to be taken care of. Yeah, this person's sick, but this person is going to be left to manage all of this grief, to carry it all. And I think both people have their own burdens through this, that especially pancreas cancer. I don't know if that answered your question, but I think I don't know, Priscilla may have some more.
No, I mean, I think
advice.
No, I think sort of in line with what you said, Dr. Mulcahy. I think, we often I often talk about the fact that there is this culture of silence that can get built up when there's a diagnosis, and everybody's just trying to protect each other. Sure. And sometimes it does require like a professional to sort of intervene to help open up that conversation. What I will say is, and I just saw that earlier this week with a couple that I worked with, where, neither partner wants to burden the other one with their emotions, and they're in different emotional places, but they both want to be present for each other, even though they're having different emotional experiences. And that's not always the case. But certainly I think the idea that there's going to be disconnection from each other ends up being a more painful prospect than sitting with some of the emotions of their loved one. And I think we can fear that if we let some of that emotion out, that it's just going to be like this never-ending tidal wave of emotions. But it actually tends to be the opposite, that the more we try to suppress our emotions, the more power they have. So, that wife who is feeling like, I'm not ready to accept this, what it would have been like to just give herself permission to just say, I am not ready. I'm not ready to let go. I don't want to lose you. I even have tears in my eyes as I say that, of the power of what it is to say that and release that. And, sometimes people are surprised at what their loved one can tolerate. And sometimes it is about talking to the person who's sick about, like, what do you need from me right now? Because sometimes it is that person saying, I don't want to hear it. And so then it's like, well, then where is there an outlet? Because it's natural for you to have those feelings, and you're just going to cause yourself more internal pain if you just hold on to that. And as I'm talking, I see Celeste nodding her head. So I don't know if you have anything to contribute from your own experience.
Yeah, I just want to say that something I really haven't talked about in so long, this aspect, because I get emotional when I talk about it, is that final phase was so complex and brought up so much emotion and guilt, and because Lou brought up all these conversations, which was amazing in the end. But then when we got to that final phase, it was the first time all of a sudden I started going between being present for him and already thinking about my life of what happens in possibly days. And then I felt so guilty. And then I was going, just, don't think about that. Now be there for Lou. You got your whole life to grieve. And it was just mind blowing, we'll say.
Yeah.
It was hard.
We could use a different expletive if we weren't on a webinar.
And luckily my best friend is a psychiatrist. So I was getting constant therapy throughout the day because it was just too much.
Yeah. Yeah.
That's what I would say. Complicated.
And I think it is that, like, here's this person that maybe has not just been there for you to support, but has been there to support you. And I think some things that is something to consider is, if you don't turn to your loved one and ask, can I talk to you about how I'm feeling? You are robbing them of one of the roles that they may have loved and took pride in the very last moments of their life.
Yeah.
Priscilla, can we talk a little bit more about survivor's guilt and what that looks like and how the best way? I mean, we talked a little bit more about, diving into that. Can you share some additional insights there?
So I think the number one thing I want to do is to normalize it. I don't know that I have sat with a single person that has had a loved one die that does not have well, let's talk about guilt versus regret. I guess I'll talk about regret. I don't know a single person that doesn't come to me and say, why did I leave the room? Why did I make them drink? Why didn't I say this? That there's some feeling of shoulda, woulda, coulda. And, I think the short answer, and I know this is such a platitude, but it really does take time. It's a normal part of the process that does sort of evolve and change over time. I think if we're talking about survivor guilt, why them and not me, right? That's a different flavor of that. And I think depending on how deep that goes, right? Is it a fleeting thought, or is it something that you're really living with, that you're really internalizing? Because I think to have the thought just comes, the feeling just comes. We can't really control that. It's just how tightly are we holding on to it and how much of it are we identifying with? And if it is something that becomes inescapable, then we may be talking about a more complicated grief process that probably does require professional help. But I think to have those thoughts and feelings, I think that idea of first aid for your emotions, that accept that you're having the feeling, identify you're having the feeling, and then figure out what do I need to do to just let it out a little bit. That's going to be helpful to just sort of moving forward, because it is so common for us to have that experience. Sure. And I saw Celeste, I don't know if you had anything to contribute, because as I was talking, I don't know if there's anything, I don't want to put you on the spot, but I just didn't know if you had any thoughts that you
Oh, I know everything. Everything resonates basically in your whole presentation. So, no, I would agree. And that's certainly something we talked a lot about in my support group afterwards, or bereavement group. And it was just really helpful to process it, talking to others about that feeling.
Yeah. And I do think that peer support is so helpful, especially it's helpful at any age, but I think especially for people who were in Celeste's situation where you're losing a spouse at a younger age, and you can't really look around your peer group and find people that are mirroring your experience. And that can even be true if you're older and your friends have spouses, or adult parent loss is often a very invisible loss to people, because you're still going on with your life as if nothing's happened in many ways, because so much of your life is staying the same. So that can be very isolating. So I think sometimes that having that sense of community can help with resolving some of these feelings that otherwise people can have a lot of guilt and shame around those feelings, because I should be doing better, or I should be moving forward differently.
Yeah, I think, there's a couple things there that resonated. The idea of moving forward or moving on. I loved that you debunked the myth DABDA, of the stages of grief, because it is such an evolution. And, on some levels, that grief is always going to be a part of you. It's a matter of your response at the time. Going back to the support groups, the notion, as we all like to talk about, of not being alone and having others who get it and give you the permission to say the things that you're not supposed to say. I think that often comes up and is really important to connect with those other folks.
Yeah.
Are there any books or online resources that you would recommend people read, whether it's on grief or on setting up, end of life care?
I'll let Dr. Mulcahy take the second part, if that's okay. I'm putting you on the spot.
Yeah, so are there books? It depends on what you like to read. So one of the books that has really brought this into the conversation is Atul Gawande's book, Being Mortal. And that was a couple of years back now, but that was like New York Times bestseller, and it was on all of the morning shows and everything. And it was a book about advanced care planning and death and dying, which was not a usual popular book to be reading, but it was everywhere. There's, so that one I think really does, he's a beautiful writer, and he's very, I think he does a good job of covering all the bases and really taking you through that. The other one, there's one, When Breath Becomes Air, and this is written by a woman whose husband, they were both medical residents. He was a neurosurgeon. They were in their residency, and the book itself, he was a great writer, little dense, very wordy, but he wrote this book as they were going through this experience. And the epilogue that she wrote at the end is probably the best part, and it's really amazing. And it really shows the struggles they went through. And it was struggles. They were a young couple, just getting married, just starting their life, finishing their residency. And then he's diagnosed with a brain tumor. No, lung cancer. And it really is something that shows a couple of things. One is that these things happen to everybody. I mean, there's nobody immune to cancer. There's no preference for class or color or where you live or what you do. It can happen to anybody. And they really take you through their experience with this in it's very beautiful writing by both of them. Yeah. So those are some of mine.
Yeah.
And I will just say, I will just admit that I'm not huge on book recommendations. That's just me. That's not that there's not great books out there. I think the one book that I consistently recommend is The Year of Magical Thinking by Joan Didion. It's not a cancer loss, but some of you may know Joan Didion is an author. She's married to an author, and he dropped dead suddenly of a heart attack, I think. And I just think it just does a lovely job of really talking. It's a memoir, and talking about what that experience is like as you struggle to come to terms with the loss of somebody that you care for deeply.
Great. Thank you for that.
One.
Oh, go ahead.
So another one that's of interest, I read it a while ago. It's called Option B. And this is by Sheryl Sandberg. Her husband died suddenly. And Adam Grant, who is, Adam Grant wrote Think Again. He's got a number of books about just sort of how we frame things, how we think about things. He's brilliant. And they wrote this book together about Plan B, when Plan A doesn't work out, essentially. So it's a lot about grief and kind of getting your hands around it and how to get.
Yeah, and her big theme is resiliency, and I think if that's the kind of a theme that speaks, that I did enjoy that as well.
Yes, it's definitely a great book. So we're going to ask one last question, because we want to be cognizant of our speakers' time. And if you have other questions, keep putting them in the chat. Email them to us. We'll be sure to reach out to our panelists tonight and get those answered to you or for you. So what are your suggestions if you don't have a strong support system? therapy, psychiatrists, meds don't seem to be working well anymore. And it's so hard to try new things and meet new people because of COVID. And your biggest support isn't herself because a brain tumor is affecting the way she is. So it sounds like this person is looking for that camaraderie of you're not alone, and the Zoom aspect of it and being alone while not alone seems to be impacting as well. Any insights? Perhaps Celeste, you have one maybe that you can start.
Well, what I would say, COVID certainly has presented such a unique situation, unfortunately, with this. But what I have done is a lot of people know that I'm really beyond open to just chatting with anybody who feels it might be helpful, and just sharing experiences and talking. And so even after we passed that, we weren't in a COVID lockdown, but I had a lot of phone calls and people were very open to getting. And I just felt being on the phone is just hearing voices directly was felt different than Zoom, we'll say. So, I don't know if there's that type of opportunity, but I know I have actually done quite a bit of kind of, calls with individuals, and just, kind of sharing stories that way. So just one idea, because I think sometimes we think people aren't receptive to that. And then by offering that or whatnot, and a lot of times people will take you up on that. So maybe some type of phone relationship.
Okay. Priscilla, Dr. Mulcahy, any other to add to that question? And
I can chime in, or Dr. Mulcahy, go ahead.
No, I was just going to say, I think it's really been, it's been a terrible year. I'm hoping year and a half. There are some things that I'm hoping we have learned that we will be able to carry over. And I'm thinking about this all the time, like through our cancer center, managing COVID. And we're learning some things that it's like, we should have done this all along, and some of it is these presentations. Granted, I do miss being in a room with people and we have our discussions when we ask our questions on our slide, but I think we reach a lot of people this way. I think if people are more, a little more savvy with these Zoom meetings and things like that, and hopefully this is going to give people the opportunity to reach out and be involved, even when they can't leave their home. Because we run into this when people are just too sick and it's too much effort for them to go to the wellness house, and we know there's so much that they're going to get out of it, but it becomes a chore, and that's not what anybody's shooting for. So I'm hoping that some of these Zoom meetings and things, it will bring some people closer together, and it will provide people with some more support for shared experiences. Certainly it doesn't replace one-on-one personal being with somebody. I mean, I went with this with my mother, who was alone for a long time for this reason. She really missed just being with people, and kind of opening up a little bit, but I empathize with that. And I just, I'm hoping we can learn something out of all this and maybe bring people together in other ways that are safer.
Sure.
I would add, I think there are organizations, things like Immerman's Angels, that provide mentor programs, peer mentor programs, both for patients, but also for caregivers and loved ones. So sometimes that can be an option if you're really craving talking to somebody who has been in a similar situation. I think the other question that I would have, if this person is in therapy, does that therapist have experience working around chronic illness? Does that therapist have experience working around trauma? Because those are specific specialties. And nothing against the therapist that a person may be working with, but when you start out in therapy and it's not related to illness and it's not related to the trauma of a cancer diagnosis, that therapist may be working with you from a particular viewpoint and a particular orientation that is going to be different than how your needs may be met. And that's why, like at the Cancer Wellness Center, honestly, we, not all the time, but we do on a regular basis have people who they have a therapist that's been working with them with depression, or they have a therapist that's been working with them because their child has autism. And those people just don't have the same knowledge and sensitivity to what the cancer experience entails. And what may work for depression when you have a chronic mental health issue may not be the same strategies that are going to help you when you're dealing with the real loss of somebody that you care for, or the progressive illness of somebody that you care for. So, I think finding specialized care for the situation that you're in can be a helpful step if you're looking for professional support. I think I just want to echo what Celeste and Dr. Mulcahy said, is that we certainly have unique challenges. We are bonding by nature. We need other people to help us feel grounded. That is just how we're wired. And this has just been a challenge to everybody's systems. So some of it may be about granting yourself some grace and thinking about, in addition to other people, are you giving yourself the opportunity, or enough of an opportunity, to do the things that feed you as an individual? Do you need to take a little extra time to be listening to that music, or walking in nature, or whatever it is that may ground you? There's not just one answer, but tuning into yourself to figure out what helps me feel grounded after I do it, and can I be doing that a little bit more frequently? A little can go a long way.
Absolutely. Well, thank you so much, Dr. Mulcahy, Celeste, Priscilla, for sharing such important insights tonight. Thank you to Savina and Cancer Wellness Center for partnering with us. And thank you to everyone who has joined us tonight for leaning in with us and asking such candid questions, heartfelt questions. Again, if you do have additional questions, send them through to info@rolfefoundation.org. If you're catching this on the replay, go ahead and mark replay in the comments and ask your questions, and we'll get back to you on those as well. So I hope that you'll join us next month. On September 22nd, we'll have Allison Klein, who's the Director of National Familial Pancreas Tumor Registry at Johns Hopkins, and she'll be talking about the role of family history in pancreatic cancer and what you need to know. You could find a link to the registration in the chat. And if you have ideas for future Wellness Wednesday editions, topics, speakers, please email us at info@rolfefoundation.org. On behalf of everyone at Rolfe Pancreatic Cancer Foundation and Cancer Wellness Center, thank you so much for joining us tonight. We hope that you stay healthy and take good care. Good night.
Thank you, Erin.
Thank you.